It's such an honor to be here and have the opportunity to share my work with you all. It's really a special occasion, and again, such a pleasure to be here. Before getting started, I do want to acknowledge several of my colleagues are here in the room, colleagues who have co-authored some of the work here, colleagues who have helped design the slides, et cetera. So I'm really grateful to have them here and really appreciative of the collaboration. So I'm going to be talking about how cash transfers save lives, but I'm going to get there in a little bit. I want to start from the beginning and just give a little bit of background on where I came from, where my intellectual interests started. So that's a photo of me. You may not recognize me there. That's a while ago. That's when I was in graduate school studying economics, as Emmanuel mentioned. I started graduate school in the mid-90s and was very focused from the start on issues of global inequality. I, even from a younger age, was focused on that issue, interested in international development, and early on decided to focus my work on the sub-Saharan Africa region. And the reason why really was because then, at that time in the mid-90s, and still today, sub-Saharan Africa is the world's poorest region by far. It's the region with the lowest living standards, the region with the fastest population growth, lots of political violence, armed conflict, and also the region with the worst disease burden. So child mortality is high. HIV/AIDS was especially exploding in the 1990s, and a whole range of tropical diseases affect people's lives. I chose to study economics thinking that if we could improve people's lives, if we could improve economic conditions and the amount of resources that African societies had through economic growth and development, it could also help deal with a lot of these other challenges, these other problems that African societies faced. Economics in the mid-1990s was different than economics today. So economics in that period and earlier was a largely theoretical field. It was a field very much driven by models, intricate, interesting, important models, but models that also relied on a lot of assumptions about human behavior and how society worked. And really starting in the 1980s and 90s, economics started changing and became a much more data-driven field and a much more evidence-oriented field. And actually a lot of the original push for that was driven by our colleague here at Berkeley, David Card, who won the Nobel Prize in economics a couple of years ago for his work. So economics started with this theoretical orientation, but it was changing. And when I started grad school in the mid-1990s, it was becoming data-driven, but we still faced a lot of challenges in doing that kind of data-driven, evidence-oriented research in low and middle-income countries, like in sub-Saharan Africa. So some of the challenges we faced, first of all, was a lack of data. African countries didn't collect systematic data the way governments or firms did in rich countries. It was hard to understand causal relationships between policies and outcomes because of feedback effects. And beyond that, when we looked to forge collaborations with colleagues, there was really limited research capacity, especially in a lot of African contexts at that time. So a lot of the early research that we did involved building new relationships and building new infrastructure to do research. And as Emmanuel alluded to in his comments, one of the big changes that I was really fortunate to work on during graduate school with Michael Kramer and others was some of the earliest, or one of the earliest or first earliest randomized controlled trials in development economics. So a randomized controlled trial isn't a new thing. There have been medical trials for a long time, agricultural field trials for a long time, but they were relatively new to economics, and they were a tool that has proven to be quite powerful. When we carried out these trials with treatment groups and control groups, because of the lack of data, we also had to organize original data collection. So these things went hand in hand, and we ended up spending a lot of time in those early years in the countries we worked in, setting up data collection infrastructure, gathering the data we needed, forging the collaborations with governments and nonprofits and NGOs to do this research. And I'm going to talk about an application of this approach today. Now, while we were doing that research, many other issues arose, and actually the field has continued to evolve. So in addition to carrying out experimental work, we also began advancing ideas around open science and research transparency in our work. We started promoting data sharing. We started promoting in our work pre-registration of our research hypotheses. So actually, we started publishing the kinds of research questions we would ask before we even collected the data. That sounds very basic and scientific, right? You're supposed to write down your hypothesis and then test it, but it wasn't what was typically done at the time. We also forged a lot of new collaborations with colleagues in low and middle income countries, had new conversations about ethics. What is ethical research? What are ethical collaborations? And all these issues have really been central to the work that we've been doing. This is the high-level discussion. What I want to do now is focus on a particular policy, a policy that I've worked on, again, with colleagues like Michael Walker, my colleague here, and others at SIGA, on cash transfer programs. People may be familiar with programs that provide cash transfers to poor people and poor households. They come in many forms. They've been spreading around the world very quickly. There's now over 200 countries that have had at least one cash transfer project. And they've spread not just in poor countries, but also in rich countries. They've actually become a policy. There's a policy discussion even in the US around universal basic incomes and cash transfers of various forms. So I'm going to be focusing on this issue in an African setting. But again, it's an issue of global interest and concern. And really, it differs, the approach, the mentality, the philosophy behind unconditional cash transfers is really quite different than traditional foreign aid. So traditional foreign aid, like structural adjustment programs that people may be familiar with, tied assistance from rich countries to having poor countries, a sort of quid pro quo. We'll give you the assistance if you carry out certain policy reforms or do certain things that we want you to do. Unconditional cash transfers are meant to be distributed and put in people's pockets directly, in poor people's hands, to spend as they want. The idea being that they would understand better than anybody what their own needs are. They know what what they need to improve their lives more than any donor or foreign aid organization. So it's very attractive, and I think ideologically very attractive, but there's a very active debate around these cash transfers. Are there downsides to them that we could measure? And even if there aren't direct downsides, is this really the best use of funding? So this is something that has been really central to the mission of SIGA and my own work throughout, is comparative cost effectiveness, trying to understand where we get the greatest bang for the buck in foreign aid. And for instance, is it better to spend money on cash transfers to the poor or to invest in public infrastructure or public goods? Would it be better to use all that money to build roads so people can bring their crops to market, or build clinics so they can take sick children to make them well? These are open questions, and really, these are the kinds of things that motivated the research project that I'm going to talk about today. So what I'm going to discuss is a project that we launched in 2014 in Kenya, a project that provided unconditional cash transfers targeted to poor households. In the parts of rural Kenya where we worked, targeted to the poorest, roughly 1/3 of households. And in rural Kenya, the poorest 1/3 of households are quite poor. Very often their basic needs are not being met. So this cash is very important for them. We work with a very well-known NGO called Give Directly. They were pioneers in this space in providing unconditional cash transfers through mobile money. So transfers that landed in people's phones. So Kenya was actually a pioneer in Africa and in the world in mobile money and mobile finance. So people can get money, send money on their phones. Give Directly took advantage of that infrastructure to have efficient transfers of cash to people. And they were very large transfers. So their model at the time was to give households a transformative amount of money, $1,000 at that time, which was 75% of average household income. So the equivalent in the US, 75% of average household income, would be like a transfer of tens of thousands of dollars to households here. So households would get this cash. They got it in 3 tranches, separated by a few months each. So over 8 or 9 months, they would get this $1,000 in their pocket, poor households. So in total, the project was very large, and we worked with Give Directly to mobilize donors to raise money for this study. Give Directly agreed to carry out a randomized controlled trial with us to try to understand the impacts of this program, and we worked with them to raise $11 million in cash transfers. So about 11,000 households received cash transfers through the study. It's a pretty large-scale study, as I'll talk about, and the size of the study is very important because it gives us the sample size we need to have some statistical confidence in what we're saying in terms of results. You may also ask yourself the question about ethics. Wait, some households are getting cash, some aren't. I will say at the start that these 11,000 households are really just a drop in the bucket of poor households in Kenya. It wasn't like Give Directly had the money to provide cash transfers to all poor households in Kenya and they kind of excluded some households. This is a very small share of poor households. And the approach they took was that given they were targeting the poorest households already, this arbitrary allocation was something that they saw as fair. Of course, it was very useful for us as well that they agreed to a randomized controlled trial, because then we can also understand the impacts of these transfers. Maybe that'll help the design of the next study that carries out similar approach and provides cash transfers. So we're going to benefit these households, but hopefully learn something that changes public policy, that changes NGO policy going forward. So how does this work in the field? I think for people that are new to development economics, it's maybe a little mysterious how our projects are organized. Because there is a lack of government data, we don't have comprehensive economic data in rural areas. We don't have a comprehensive vital statistics system in most of rural Kenya. We had to collect a lot of data ourselves. We raised funding from the National Science Foundation, from others for this research, and carried out large-scale data collection. We actually censused 65,000 households in the study county of Siaya, Kenya. The total population in those 65,000 households was 300,000 people. We censused all of them. We censused over 10,000 enterprises, every enterprise in the region, from the smallest one-person shop to the largest businesses in the county. And we're doing this so we can measure economic outcomes and health outcomes as accurately as we can. But of course, this was a major undertaking. There was a team of over 80 enumerators or surveyors working for multiple years. And in fact, we started in 2014, as I mentioned, but we're still collecting data today. We're still collecting the 10-year follow-up data. So I won't have anything to say yet because we're still collecting that data, but our goal is to understand this program in real depth over a long period of time and with statistical precision because we have a large sample. We partnered with some great organizations, Innovations for Poverty Action and Remit Kenya, who provided a lot of research expertise to enable us to collect this data and carry out the study. You see some photos here of data collection going on. That's me at the top. I'm not the one collecting the data. I was just visiting the field team, observing what they're doing, learning from their experience. This was just last year. All right, so I'm going to talk about two things. I'm going to talk about economic impacts of the cash transfers, and then we're going to jump into the health impacts. The title of the talk really focuses more on the health. But let me start with the economic impacts and ask the first question: how could cash transfers going into the economy change economic activity or stimulate economic activity? This is a very old question. It's really a macroeconomic question. You can go back at least to John Maynard Keynes and before for very serious thinking about how stimulus spending, government spending, cash transfers have an aggregate effect on the economy. So let me just go through an animation that illustrates this. This is our recipient of cash transfers in Kenya. He's getting money on his phone here, a mobile money transfer. And how could this affect the broader economy? Well, if he spends that money at a local shop, buying goods, buying food, buying clothes, that's going to stimulate economic activity. That shop is going to get more business and more revenue. And in fact, in our data, we find a very high rate of consumption. What economists call the marginal propensity to consume is very high. Within a year of getting this large cash transfer, over 80% of the money is spent. Very little of it is saved. So imagine, these are poor households that are targeted, living near subsistence. When they get $1,000, they have a lot of needs: food, clothing, other things. And they tend to spend it in local shops right away. But that shop owner himself could then spend the money. He may go to another shop to buy things that he needs. Or maybe if he's getting enough new business because of all the economic activity in the area, maybe he hires some additional workers, which affects other people's earnings, and so on. So this is how a stimulus like cash transfers could affect local economic activity. Really, the money circulates through the economy, and central to all of it is these high rates of consumption, high rates of spending. If when people get the money, because they're poor, they tend to spend it quickly, you tend to get a pretty large multiplier effect. At least that's the theory. But it's been hard to test rigorously with data. And the reason it's been hard to test, even though it makes a lot of sense, is because when stimulus programs, when cash transfer programs are implemented, it's hard to know what the right counterfactual is. So here, this is another nice graphic. Imagine that the blue area here is an economy where there's a lot of cash transfers going in. A lot of poor households are getting cash transfers, and the orange ones are economies where cash isn't going in. Typically, those policy changes take place at a large scale. Maybe a country has a new anti-poverty program, and the whole country is just, around the country, cash transfers are being distributed to the poor. Now, if we want to understand the effect of those cash transfers on the whole economy and what the multiplier effect is in economic activity, what do we compare that country to? Do we compare it to its neighbor? Well, that's not a great comparison. Maybe those countries differ in many different ways. May not be a good comparison. Do we compare the country the year before the cash transfer program was launched to the year after it was launched? Okay, maybe that's a little better, but still lots of things change over time. There's secular trends, there's other economic shocks and things that occur. So in the macroeconomic literature, it's been hard actually to credibly identify and understand the effect of this kind of cash transfer program, even though it's intuitive that it would have a very big effect in some settings. So this is where randomization could come in. Now, the simplest form of randomization would be like a simple medical trial or simple economics RCT, where we randomize certain households get cash and certain ones don't, or maybe a village here gets it and the neighboring village doesn't. That doesn't necessarily help us solve the problem, though, because if you randomize this household gets a cash transfer and their neighbor doesn't, they're still interacting in the same local economy. You may be able to estimate the effects on that recipient household of getting cash, but not really the aggregate effects on the broader economy with that kind of simple, very micro level RCT. So the macro level analysis was problematic. The very micro level analysis, it's hard to understand broader effects. So what we did in this study, and one of the things that was innovative, is we added a layer of randomization. We effectively randomized at an intermediate level. So what we did in this study is we took sub-regions in Kenya and Siaya County called sublocations. And the sublocations typically have about 10 to 12 villages. They have a market center. So that area of several kilometers, radius is really a local economic activity area. Most people do their shopping there, they work there. And what we do is we gather a large number of those sublocations, 68 different sublocations. And because we had enough funding and large enough a sample, we could vary treatment at that level rather than just at the household level. So 30-something sublocations were high treatment sublocations, and 30-something sublocations were low treatment sublocations. And then we're going to look at the difference in economic activity at that level. So rather than the country level or the household level, we have this intermediate level. Now look at this design. You'll see the colors don't line up perfectly, and that's by design. So if you look at the left, the blue circle is the high treatment region. There, the vast majority of poor households are getting cash transfer, but some don't. Some are randomized in, some are randomized out. What's the reason for that? Analytically, in terms of the statistical analysis, that orange household in the blue region that didn't get cash allows us to separate out the effect of getting cash from the spillover effect from the local economy. They didn't get cash, but they're in a region where most people around them got cash. If their economic outcomes improve or change, it's not because they got cash, they didn't. It's because they're benefiting from this local multiplier effect. The same thing holds on the other side. In the orange region, there are these few poor households that were randomized into getting cash transfers. They don't benefit from the local multiplier spillover. Very few households around them are getting cash, but they get it directly. So for them, we can estimate the benefit of being a recipient alone without that broader multiplier effect. So we have a design that allows us to estimate different effects that then we can add up to a total effect. And in fact, in some of the analysis I'll talk about today, we're going to be mainly comparing the blue households in the blue region, so they got cash, and most of the poor households around them got cash, to the orange households in the orange region. They didn't get cash, and few of the households around them got cash. That's the largest difference in exposure to cash transfers that we have given our research design, and that's going to be a big focus today. All right, so this is a methodological innovation of the approach that helps us start answering questions that weren't answered as well before. And in fact, the map here is actually the map of Siaya, Kenya. You can see those blue and orange areas are the different sublocations, some randomized into high treatment, some into low treatment. And we're going to be comparing outcomes across these regions to understand how infusions of cash don't just affect recipients, but affect the local economy as a whole here. Okay, so what do we find? First set of results. I said I'd start with economic impacts, then I'll get on to health impacts. The first thing we find really replicates earlier findings. If you just look at the recipients of cash, they do better. they spend more on food. They spend more on clothing. They spend more on their kids' school fees. They spend more on household goods. They do better. There are already RCTs showing that among the direct recipients. What's new about the study is our ability to compare across these subregions. So there, what we're able to show is if you look at total economic activity in areas, for every $1 in cash transfers that's given to the poor in one of these sublocations, total economic activity over the next few years goes up $2.5. So in addition to that first dollar, there's another $1.50 of economic activity. And again, that's because, and we document this in the data, local businesses' revenue goes up. They start hiring more workers. And even if you look at households that never got cash, their spending goes up over time. Their earnings and profits go up. There are very measurable, large spillover effects of cash transfers. So that's the 2.5 multiplier effect. Now, there's some concerns about programs like this, some concerns about cash transfers. There could be downsides. So one potential downside is inflation. That's a big issue in our country right now, the last couple of years, as everybody knows. There's a concern that if you put a lot of cash transfers into an area and a lot of people have more money and they're all trying to buy the same goods or the same products, it could bid up the price of those goods. We do find that there's a little bit of inflation in the areas that got a lot of cash, but it's only about 1% or less than 1%. It was minimal. So it goes in the right direction, but it wasn't that large given cash transfers of this magnitude. So that wasn't as much of a concern. And in fact, if you do the adjustment for inflation, so you have what we would call either real or nominal multipliers, they're very similar in this case. The other concern with cash transfer programs, whether it's in Kenya or the US, is are there going to be negative behavioral responses by the recipients? Are they going to just stop working? Are they going to spend all the money on booze? There's a lot of caricatures about what poor people might do when they get cash. And we try to measure those different effects. We don't find negative effects. We don't find any disemployment effects. And we're not the first study. A whole bunch of randomized controlled trials that distribute cash in poor countries find the same thing. When you give poor people in poor countries cash, if anything, sometimes they work more because the money allows them to start a new business and actually have more economic activity. So we don't see more unemployment. We also don't see lots of spending or misuse of funds on alcohol or gambling. The vast majority of spending went to people's basic needs. They spent it right away because they had a lot of basic needs, really within the first year of getting the cash transfer. So this is the economic impacts. The paper these results came out as cited at the bottom. It came out in an economics journal, Econometrica, a couple of years ago. And again, my co-author, Michael Walker, is here in the room. All right, that's the economic impacts. What about health impacts? These are new findings. They're not published. We've been working on them. We're still collecting data in the field, but these data were data we collected last year for the most part. How could getting cash affect child health? I think there's a lot of reasons we might think child health could improve if households get cash. First of all, and this is the nice graphic again. Someone's getting a cash transfer distributed through mobile money. There's a couple different ways it could affect health. So one is they just have more cash in hand to actually go spend at clinics and at hospitals for their kids' health. Maybe for the delivery of a child, maybe when a kid gets sick, for checkups, et cetera. The other thing they could spend on that's potentially important is transportation to a clinic. And you might say, well, how is that a big issue? It actually is a really big issue. In the baseline sample for our population in 2014, guess what percent of households owned a car in rural Kenya? It was 1%. What percent of households owned a motorcycle? It was 8%. So only something like 9% of households had ready access to transportation. And a lot of them lived quite far away from hospitals and higher level medical facilities. So actually transportation becomes very important, potentially here. If you have money in hand, you can access care and you can also get there. So distance to clinics and hospitals is going to be potentially important here, but more than anything, you have the money in hand. That said, it's not a guarantee that getting more money will improve health. You could get more money, but spend the money on something else. People may have other priorities. They have a lot of needs, schooling, food, other things. Maybe they'll spend on other things. So it's not automatic that child health would improve. We're very interested in this study on one very important aspect of child health, which is just survival. So child mortality was our focus, and we designed data collection, given the absence of government data, comprehensive vital statistics data. We designed data collection to measure this. What did we do? This was in 2023. We censused all the households in this area again. We got over 60,000 households surveyed. It was a huge undertaking with another really large team. It's a lot of blood, sweat, and tears that goes into this work, as you can imagine. And 90-something% of households spoke to us and gave them their data. So that was great. We have a very representative sample in this county that has about 300,000 people. And from each of these households, we collected the full birth histories of women in the households between 2011 and 2023. Every kid they'd had, as well as, sadly, cases where kids didn't survive. And infant mortality and child mortality remains quite high in Kenya, an order of magnitude higher than it is in the US. So we collected that data. In total, because we have this really big population and this huge effort, we collected data on over 100,000 births. So this is becoming a really big data set, and it gives us the ability to say things with a lot more statistical precision than we might with a much smaller data set. We wanted to go beyond just the deaths and the births and that basic data and understand cause of death, what was really going on. So we collect data on what are called verbal autopsies. So everybody knows what an autopsy is. A verbal autopsy is collected in settings where there isn't a physician or a pathologist or others who can really determine the cause of death with certainty. But it's a series of survey questions that are asked of people that point towards a cause of death. And then there's basically efforts that have been done by the World Health Organization, also by the Kenyan Medical Research Institute, KEMRI, to administer those surveys to a survivor, let's say a spouse or a parent of someone who has passed away, and compare them to the official cause of death. And then you can use statistical methods like machine learning methods to predict cause of death just from the survey data alone. So that's what's been done in Kenya. We're really fortunate that the Kenyan Medical Research Institute carried out an exercise like this to create a machine learning algorithm to predict cause of death in our very study county just a few years ago. We were able to use that, the kind of take advantage of the training data that they had used. So we collected verbal autopsies. We had the KEMRI experts train our entire team. These are very sensitive surveys. You're asking typically a mother or father about a child death. It's a difficult survey to fill in. The KEMRI team trained our team on how to be sensitive, how to be culturally appropriate. Of course, all of our enumerators are Kenyan, so they're operating in that environment, but it's still a difficult set of questions to answer. And something like 85% of surviving parents answered the survey. So it's not 100%, but we're getting data on the vast majority of people, and we have a sense of the cause of death. There's another 12 or 15% of parents who didn't want to answer the question, very understandably, of course. Finally, then we apply the machine learning algorithm to predict the likely cause of death. All right, so that's the data environment. It took a lot of effort. We had to learn a lot about health data collection, train this team, but then we have a pretty unusual, pretty unique data set here combined with the earlier RCT. So what do we find? I'm going to start showing you some results. Let me explain this figure a little bit. The vertical axis is the infant mortality rate per 1,000 births. Again, in the US, this is just a few per 1,000. In Kenya, it's going to be more like, as you'll see, 40 per 1,000, so a lot more. The horizontal axis is the time period. There's the pre-cash time period. The cash was distributed between 2015 and 2017. So pre-cash was 2011 to 2014. And then there's the post-cash period, 2018 to 2021, 22. So what does the data look like? Let me start with the control mean. You can see the red there. The control mean is the average for the control households. These are the poor households, but they didn't receive cash in the low treatment areas. So this is what infant mortality looks like in the pre-transfer and cash period. It's pretty flat. It's around 40 deaths per 1,000. How about the treatment group? The blue here is going to be treated households in the high treatment regions. So kind of getting the largest exposure to cash transfers. And there's some pretty interesting pattern here. First, in the pre-cash period, the blue and the red dots lie right on top of each other. They're the same. They both have the same infant mortality, as you'd expect in a large-scale experiment. With randomization, there should be balanced characteristics in the treatment and control group. They shouldn't be systematically different, and they're right on top of each other. But in the cash transfer period, there's a massive drop of about 40% in infant mortality. If you can see, if you're not too far away, the gray whiskers on the slide there, that's the confidence interval on the difference between the blue dot and the red dot. And you can see the red dot lies outside those whiskers, meaning the effect is statistically significant. And in fact, This effect, no matter how we estimate it, is statistically significant at over 99% confidence. This is a very large effect, a 40% reduction in infant mortality. Okay, this is the main result of the paper in terms of the health impacts. But there's still a lot more to understand. The next thing I want you to ask yourself is what happens in the post-transfer period? This was a one-time transfer. Remember, they got 3 tranches over 8 or 9 months in 2015, 2016, somewhere there. A few years later, women in these households are having kids. Do you think there's going to be a persistent effect of getting that cash transfer? Will something change? Will they be richer? Will anything change? Well, it actually turns out that in the post-cash period, the blue and the red dots are right back on top of each other. There's no persistence of the effect. The cash transfer has a huge effect when households are getting it, but once the cash is gone and there's no more cash transfers, it's back to the status quo, about 40 infant deaths per 1,000. The same in the blue and the red, right? So this is the kind of first finding. I do want to make one more comparison though here. You can see the yellow dot. This is the control mean and what we're calling the ineligibles. Who are these ineligibles? They're the households that were too rich to get the cash transfer. Remember, the bottom third of households got cash. The richer 2/3 of households didn't. Now, these households by global standards are not rich. They're living in rural Kenya. They probably don't have electricity. They're probably farmers still, but they're somewhat better off, and they have more assets and typically more education, et cetera, than the poorer households. So if we look at their outcomes over time, this is the yellow line, you can see something kind of interesting. Their infant mortality throughout is about 30 deaths per 1,000, considerably lower than the poorer households. So even richer households in this region are doing better, and it's pretty flat. It's kind of parallel with the red line. So in the control group, there's kind of a stable situation, but in the treatment group, when poor households get the cash, they look even a little bit better than the yellow households, just while they're getting the cash. Right, this is the main finding, but there's still a lot to understand, especially around cause of death. So what happened? What changed here? The overall effect is a drop of about 20 deaths per 1,000. I just showed you that on the previous slide. What is the breakdown? We have major causes from this machine learning algorithm, major causes of death, maternal neonatal causes, communicable respiratory, these are kind of like infectious diseases, non-communicable, child cancers, genetic disorders, injuries, and then the undetermined are the cases that the algorithm couldn't figure out what the cause was. The answers were maybe contradictory, and then no VA were the no verbal autopsy. Okay, so what does the breakdown look like? The first finding is more than half of these deaths averted were from maternal and neonatal causes, delivery complications, stillbirths, really the kinds of cases where better antenatal care and delivery services could really have made a big difference here. That's a big, the largest part of the effect. So this is already a bit of evidence that maybe access to those antenatal services and delivery services could have been quite important here. But there's effects on some of the other ones. If you look at communicable and respiratory, the largest category there is malaria deaths. There's a lot of malaria deaths for under 1 kids in East Africa. That's a pretty substantial reduction, about 1/4 of the total. I think the non-communicable one is very interesting. Non-communicable diseases here are, again, child cancers, genetic disorders. They're not a huge category, but there's really no effect on them. You wouldn't necessarily expect the household getting cash would eliminate these genetic disorders, for instance. So it's almost reassuring that there's no effect there. And then you can see, the no VA category, there's a drop, but we don't know, what the cause was because they didn't answer the survey. Okay, so this is a big indication that maybe access to the right medical care could matter. And let me show you some more evidence of that. We actually know where people live. We have their geolocated households, and we geotagged all the clinics, hospitals, and dispensaries in this whole county, and actually the ones in nearby counties that were kind of in striking distance. So we know how close people lived, how far away they lived. In a context where very few people have vehicles, they're walking places, or they may need to hire a minivan or hire someone to take them on a motorcycle farther away, but that costs money. And we divide the sample from the farthest quartile to the nearest quartile. The farthest quartile, people live 91 minutes on average from the closest hospital. That's pretty far distance, not very accessible, and some people are even farther than that. And by hospital here, we mean what in the Kenyan medical system is called a level 4 facility. It's a hospital that typically has a physician. So there are lower level clinics and dispensaries that typically don't have physicians. These will have a physician present. The closest quartiles are a 20-minute walk. That's still, on average. Some people a little closer, a little farther. That's still not trivial, but it's way closer for people. It's kind of within walking range. So what do we find? If you look at the treatment effect of cash on the people who live far away, there's a bit of an effect, this -12, but it's not very large. It's not even significant in that subgroup. But the closer you get to a facility, the larger the effect is. So this is, we think, pretty strong evidence that access to health services really matter. Getting cash is fine, but getting cash when you can actually access a doctor, access a hospital, that seems to have a really big effect, more than twice as large an effect as just getting cash, on its own and being far from those services. Okay, one last figure and result that I want to show, which has to do with timing. Now remember, I pointed out that this is a one-time transfer. You get it in 3 tranches within 8 or 9 months, and then it stops. And we know from the surveys, the birth histories, the month in which children were born, so we can go 9 months back to kind of know the in utero period, a year forward to know the infancy period. And we know when the cash was distributed because GiveDirectly share that administrative data with us. So we can ask the question, at which time point is it most effective to get cash? So the first finding is, if you get the cash, and that whole 8 or 9 month period where you're getting the cash occurs before you're even pregnant, there is just 0 effect on infant mortality. You can see that estimate there. I already kind of showed you this result with the persistence, the lack of persistence. It's sort of like, if you got cash a few years ago, it really doesn't do much for child health now. But as you get into the key periods of the in utero period, and especially the birth month, there are really large effects. So especially large effects of getting cash. If women are actively getting cash transfers in the month of birth, there are really huge effects. And then again, if they get it as an infant, it's still good because there's a lot of a lot of death in that period. If you start getting cash when the child is already greater than 1, maybe there's a little bit of a reduction in child mortality between ages 1 to 5, but it's much smaller, right? So the results so far really indicate that getting cash to the right people at the right time matters a lot. It isn't like cash on its own matters. And back to our question from before, those public investments in things like clinics really matter, and they're very complementary with cash transfers. I'll say one last thing. It's not on the slide. We've been collecting household data, as I mentioned, on people's behaviors, including their health behaviors. And we asked the question of women, did you deliver a particular child in a hospital or not? We have that data. So if you go back, and I'll just jump back, one slide for this. If you ask people in those top 2 quartiles that show the really big effects, did you deliver in a hospital? The people who get cash show an increase of 22 percentage points from 60% to 82% in delivering in a hospital. So if you live close to a hospital, a proper hospital, and you get cash, you're way more likely to deliver in that hospital. If you're in the farthest quartile, first of all, to start with, fewer of them deliver in hospitals. Only 35% of them deliver in hospitals, and there's no treatment effect. So in other words, it wasn't like they had enough money to access the transport to go really far away. They just didn't do that. But the people who live close enough really increased their usage of hospital services. So we really feel like we have evidence on the behavioral channel underlying these results, and it really looks like there's a big increase in healthcare utilization. All right, so let me get into cost effectiveness and get back towards policy and some big picture questions. With the data we have, we're able to compute how many deaths were averted, at least statistically, by this project. And now I'm going to look at under 5 deaths, which is our most comprehensive measure of child mortality. In our analysis, there's about 28 fewer under 5 deaths per 1,000 births. Remember, it was about 20 or so under 1. It's about 28 fewer under 5 deaths per 1,000 births. Really big effect, about a 40% reduction. And in the high treatment areas, in those years where cash was going out, there were about 3,300 births. So we can multiply those numbers together and come up with, there were about 96 deaths averted. The statistical analysis indicates from this project. This cash transfer program saved maybe about 100 lives. And again, for us as researchers, it's pretty exciting to think that we helped to raise the money and mobilize donors behind this program, and to think that so many lives appear to have been saved. Now, the next step is a little more controversial, a little more speculative. in public health policy and in health economics, there's often a need to put dollar values on reductions in morbidity, to put dollar values in health benefits, to put dollar values on mortality averted. This is kind of controversial, feels like a terrible thing to do, to put a dollar value on, reducing illness or death. But public health policymakers who have very limited budgets are trying to allocate money as effectively as they can, and they're trying to maybe get the most deaths averted, get the most healthy lives as they can. So they put dollar values on these things to make comparisons. I'm not going to stand behind these values. We could have a debate, about what the right value is. One pretty prominent foreign aid donor, GiveWell, has suggested a weight of something in a kind of East African context that a life saved is, could be valued in these trade-offs at something like $90,000 or $100,000. Okay, again, I'm not going to stand by this number as the gospel, other than to say this is the kind of number that policymakers are using when they're making trade-offs and they're allocating resources. If we take that number seriously, the value, the benefit of these lives saved would be something like $9 million. So that's a pretty large amount of money, especially when we consider that the total cash transfer was $11 million. And there were a lot of benefits of this cash transfer program. All the direct benefits for recipients, the schooling for their kids, the food, the better nutrition, the spillover effects, the multiplier effects, and these health benefits. So, this is an important input into the policy debate. And we really couldn't have gotten these numbers or had these inputs if we hadn't gone through this multi-year process of collecting a lot of data and having a kind of research design that makes sense. There's other kinds of cost effectiveness calculations you can do. One of the ones that we've done is to say, what if we targeted all this money to women who were pregnant? So they had cash in hand in their birth month. I just showed you that was a very cost-effective moment to target the funds. And especially the women who live near hospitals. They have the biggest reduction. If the money was targeted to women who had access to health care in their birth month, the cost per death averted would only be $15,000. Now that may sound like a lot, but that's very cheap. And based on the WHO standards of what is a cost-effective intervention to reduce child mortality, this would be among the most cost-effective ones. So again, the right kind of targeting at the right time could really improve lives, and we could spend resources more effectively and more efficiently here. So punchline from this cash transfer study, and back to the initial debate, cash alone may be good in some ways, but it didn't do much to save lives. But cash combined with access to healthcare, especially access to a trained physician and hospital, had a really big effect. And the cost effectiveness of that investment is just way better than a lot of others that are out there in international development. All right, let me step back a little bit and go back to the big picture. Emmanuel already alluded to the work that's been done and that's currently being done at the Center for Effective Global Action, CIGA. I'm the faculty co-director and helped to found the center. This project, this methodology, the field experiments, the data collection, this focus on issues of real public policy concern and public health concern, this is really typical of the kind of work that CIGA does. We've funded hundreds of studies over the last 15 years or so in 60 countries around the world. And along the way, we've built up a lot of research infrastructure, a lot of research partnerships in those countries. We've also forged a lot of new collaborations with scholars in low and middle income countries, and we've focused in particular on scholars in African countries. It's been just an amazing experience to build up the footprint of the center and collaborate with East African, West African, Southern African scholars. Several dozen, I think 60 African scholars have visited Berkeley for a semester for training in these methods and for work and mentorship with faculty like myself and others in the room. And it's just such an incredible pleasure to work with them, and also really an investment in research capacity in countries around the world so that more research of this kind can be carried out internationally. We've forged a lot of collaborations. I already mentioned IPA and REMIT. This is a photo of some of our scholars, CIGA scholars who were visiting Berkeley a few years ago at a conference we were organizing in Nairobi. And after all this investment and work, Berkeley has become one of the leading global hubs for this kind of research and international development. And it's something that I'm really proud of. And I'll go back to what Emmanuel, opened with. I've been at Berkeley for over 20 years. My whole career as faculty. I've been here since finishing my PhD. I'm so happy to be here. I'm so proud to be part of this community. And really, it's an incredible honor to have the opportunity to share this work with you. And I look forward to the discussion and conversation in the Q&A. Thank you.
Thank you very much, Ted. So Jane is bringing the microphone. So please stand and line up behind the microphone, to ask your questions.
Hi, thanks so much for a wonderful talk and a most important and impressive study. I'm a public health faculty person, not here, but at Emory University. And in fact, verbal autopsies are very problematic, as I'm sure you know. And also, malaria is a global catch-all, but there are a lot of overlap between malaria and childhood respiratory disease, terminal diarrheal disease, which are the big infant killers. So my question is really, do you know anything about vaccination status? Do you know anything about water supplies? You're ascribing this to health facilities, but as a public health person, I would like to know whether the vaccinations they received or access to clean water could be other explanations. Also, are you aware that there's something called minimally invasive tissue sampling where you can validate verbal autopsies? And I'd be happy to chat with you about that.
Yeah, well, I'm not going to do any autopsy myself as an economist, but thanks for the suggestion. I'll let you do that. So much in there. So verbal autopsies, so problematic. The best we can do, given no vital statistics, no pathologists. So, in terms of the classification, there is a kind of classification, accuracy, in the model. And so you can set the threshold, where you want it. And there were about, 10% of the cases where they couldn't quite reach a cause. So there's definitely some noise there. And, the best we could do, given the lack of proper data in other ways. In terms of other causes, we looked at a lot of things. So there's a lot of things that could change. So you might say, well, when you get cash, now all of a sudden your kids get vaccinated. So in these cohorts in Kenya, vaccination rates are actually very high. They're the highest in East Africa. They're in the mid to high 90s, even in the control group to start with. Now, that doesn't mean they necessarily get the full series or whatnot, but I think it's 98% of kids get some vaccination and a large share get a lot. So we didn't see any action there because they were kind of top-coded. At that point. We have information on water supply. We don't see changes there. So we were thinking along those lines. There are some channels. I didn't even bring them in just for a shorter talk. But I'll mention two other things that we think also contributed. I put a lot of weight on the health facilities because the results are pretty strong there. But there's two other channels that are pretty interesting. So one is child nutrition improves. And we have that data. And when households have more money, we have it in their kind of spending modules. They're spending more on food. So that has to be part of the story. Now, it's not probably going to affect like the neonatal deaths or the delivery deaths where we see a lot of action. But when we go to the under ones and under fives, that could be part of why we do see some under fives nutrition. There's another really interesting one, which is we collect very detailed data as economists on labor supply, labor activities. And we see an effect on women's labor supply. So we know which trimester women were in when they got the cash. And we focused our analysis on the women who were in the third trimester. So in the control group, in the third trimester, in a typical week, women in the sample are working 25 hours a week. That's decent number of hours. In the treatment group, that high treatment area treatment group, that falls to 10 hours. There's a drop of from 25 down to 10. There's a huge reduction in work hours among women in the third trimester in the treatment group. No effect among men. No effect in the other trimester. So to the extent that a lot of these women who, again, are living near subsistence, who are often farmers, are forced for survival to be doing a ton of work right before delivery, being able to have money in hand to not have that kind of physical strain in month 8 and month 9 could be part of the story too. Again, I didn't get into it here, but that's some of the data that we're getting.
That's fascinating. Do you have birth weights?
We don't have birth weights because, again, they're not recorded systematically. We have birth cards for a subset of kids, but a non-random subset. So that would have been a great thing to have. Yeah.
Hey, Ted, thanks so much. That was so awesome. The end of your response to that great question was sort of what I was interested in, and that is when you first started talking about child death, I didn't know you were going for infant mortality, and I thought maybe it was going to be under 5 was going to be the starting point. I think I understand this is the highest rate of death, so you're going to focus starting in on these very high death rate settings. Yeah. But as you kind of zoom out to looking at kids under 5, I was really interested in the role of nutrition, as we think that and in particular, that could have a more sustaining effect on child mortality, as opposed to the impact kind of disappearing for infant mortality, which you showed so compellingly. And so I'd love to hear you talk about that, if you have anything more to say. But I also wanted to just point out that the pattern is very similar in US data. So work that I've done that doesn't look at infant mortality because, thankfully the rate isn't that high in the US context, but looking at health at birth, birth weight, incidence of low birth weight, and looking at cash transfers through the earned income tax credit, and relating when your tax credit drops relative to the birth in a similar way that you were showing here, you find a very similar pattern. That is, the improvements in birth outcomes are concentrated on the credits appearing late in the term, because that's when most of the gain in weight occurs. So that was kind of an interesting thing to see. But love to hear you talk more about a broader measure of child health to higher ages and other roles besides this kind of transportation role.
Yeah, so thanks for that. And we're definitely going to bring in the US literature. It's great that there's kind of that similar pattern, again in the US. We're very interested in longer term effects, Hillary, for kids in this sample. And I think we focused on this very high mortality period because it's so important, just survival. There are indications in our data, as I said, of improved nutrition, better food security among kids. One of the things we want to do, and we want to actually fundraise for, is the next round of surveys will be to look at these same kids. So again, this was like 8 years ago, and to do much more detailed surveying of these kids' health, nutrition, education, cognition, growth, to really understand the longer term effects of being young, being a couple years old, or being in utero in that range when the household received cash. So we don't have that evidence yet, but we're really excited to look at it, and we think it could be really important. So
Thank you.
Thank you.
Hey, Ted, thanks so much for the amazing talk. I'm Otis, an undergrad here at Berkeley, and I want to talk about aid more broadly in the context of Africa. And so there's this book, Dead Aid by Dambisa Moyo. I'm sure you've the thesis of that. And it's sort of a little contrary to a lot of what aid-related work in Africa is about. I would love for you to maybe summarize the thesis there for the audience, but more so talk about how those sets of ideas compare with your sets of ideas, and what's your broader idea of aid to Africa, and how do you do that while still supporting the local institutions grow in the ways they need to?
Yeah, so there's a lot there, and I think in my own career, there's been, over the last 30 years as I've been in this field, there have been a lot of very high-profile debates from like aid is very good to aid is very bad, and I've studiously avoided taking sides in those debates, and I think the results here say why. To say that aid is always good or aid is always bad is naive. Even here, the targeting of certain types of assistance at certain times in certain places has a very different effect than others. And so I see myself as a researcher, as someone who's trying to uncover those patterns and understand where aid could be good. I definitely know Dambisa Moyo's work, and it's provocative and interesting. I think some of those broader critiques that she's made, and Bill Easterly has also made, have to do with aid coming in from foreign countries and hindering the development of local institutions. That isn't as much an issue perhaps with direct cash transfers into people's pockets or citizens' pockets as some of the kind of conditionality you see at the government to donor level. So I'm not going to take kind of an editorial stance on it being good or bad. I will say that we should always be skeptical, and it's important to keep a skeptical lens on aid, skeptical lens on what we're doing. But there are a lot of big foreign aid successes. So the U.S. Under George W. Bush back in the day started a foreign aid program, PEPFAR, that has provided now, I think, over $100 billion in assistance for antiretroviral drugs. And conservative estimates of the impact of that program are that it saved like 10 million lives. So, there are huge successes in foreign aid. And it's important to debate ideas and be critical, but let's not put ourselves in camps where we stop looking at the evidence. That's what I would say.
Absolutely. Thanks so much.
Yeah, thanks.
Yeah, thank you. Thank you very much. It was totally fascinating. I've worked in Africa for over 20 years, and particularly in Kenya. Do you have any gender disaggregated data? Like you surveyed these 11,000 households. Was there a difference between when a woman received the money as opposed to when the man received the money? And is there any information whether, this is the Luo area, there was any change from monogamous to polygamous households as a result of this cash transfer?
Yeah, so all great questions. On the transfer receipt, Give Directly doesn't direct it to men or women per se. They go to a household and say, who has an M-Pesa account, the mobile money account? They transfer it to that account, and we have no visibility into who owns that account.
Okay.
So that's an issue, and it's one we've been interested in, and we've been asked a couple times, and it's just not the way their program at that point is defined. Some other cash transfer programs have been more targeted. We've been very interested in marriage patterns, fertility, and to your point, again, there is a relatively high rate of polygamy, at least by Kenyan standards, in this part of Kenya. Over the 5 years, I think it is, after the cash goes in, there's a small increase in marriages, but it's like 1 percentage point. So there's no kind of big changes in marriage patterns. The other thing we see is a small increase in fertility just in the years after cash goes in, but not a huge effect, and it kind of goes away. So we were very interested in those marriage fertility patterns, but we find kind of modest effects there.
Thank you.
Yeah, thanks.
Thank you so much for doing and sharing this work. When you sort of set the context today, you talked about sort of the ideological or philosophical appeal of cash transfer insofar as it lets people choose how they want to spend their money.
Yeah.
I'm curious if you could speak a little bit more to that, either in your work or other work you're aware of either sort of qualitative analyses of talking with people about how they experience direct cash versus other forms of aid, or kind of going in the more quantitative direction in the cost effectiveness side of things. Have there been any efforts to kind of put a number on this sort of dignity experience, the way we put a number on some of these other things when we're doing those types of analyses?
Thanks for asking that. That's a great point. There actually have been some grad students I've known who are very interested in this dignity component. As economists, it's not really in our wheelhouse to conceptualize those issues. I think they're potentially extremely important because people are getting control. They get the money, they get to choose how to spend it. They can spend it however they choose to benefit their household the most. How to measure the dignity component is a little tricky. We do have questions in our surveys around happiness and life satisfaction, and we do see gains in those areas. Now, there's a bunch of reasons potentially for those gains, like they're richer, they have more income, their children are more likely to survive. But there is, just in terms of how people feel about their life, in the couple years after cash goes in, we see an improvement. So I think that's related, but not exactly what you're getting at. And I think it's a really important issue.
Got it. Thank
for
you
sure.
so
Yeah,
much.
thank you.
Yes, thank you. Very, very interesting. I just have a couple of questions. One is, how much did spending improve agriculture? Did the households spend more money on improved seeds or other inputs? Did you look at that? Did you see any patterns? And then the other question is, how did the cash that you were providing compare to other sources of cash remittances from relatives working in the cities and so on? And was it uniform enough that it didn't sort of distort your data in some way, that you weren't looking at the whole cash economy of the household?
Yeah, thanks. On the second question, in our household surveys, we have a detailed module on transfers out and transfers in. So we ask about those relationships, the key transfer relationships. And we didn't know what to expect. You might think, well, I got $1,000 Now maybe all my relatives are going to want some of that money and pressure me, and I'm going to start transferring it out. That's part of why we measured it. We are also capturing other transfers from the city. There is a little bit of an increase in net out transfers from the treatment households, but it was very small. It was only like a couple % of the total transfer. We were a bit surprised by that. We thought there might be more. There was some earlier work in Mexico with a conditional cash transfer, the Progresa program, that showed pretty substantial cross-household transfers. We don't really see that. Here. So we were interested in it, we measured it, and it's one of these cases where we didn't see much of an effect. In terms of agricultural production, we do have measures of agricultural production. There are some gains, but they're not huge, actually. There's some gains in other sectors, in the retail sector. So we see kind of gains across sectors in the economy, but it wasn't that the cash transfers led to some transformation of agriculture, just modest improvements.
Okay.
So, yeah.
Thank you very much.
Thank you.
I have a question regarding the counterfactual households. How were you guys measuring the effect that the cash was having for the houses that weren't getting the cash? Like, what questions were exactly being asked? Like, did employment change for them? I'm kind of curious on the level of depth of because I think that's really fascinating, and what's lacking in other works on cash transfers is like capturing that effect.
Yeah, so we asked the same detailed survey to everybody, regardless of the group that they were in. And we really model our surveys on the World Bank Living Standards Measurement Surveys, which are kind of the gold standard measurement for employment, agricultural productivity, consumption, like what they're spending on. And everybody got the same surveys with very detailed questions on labor supply, type of employment, those kinds of things. And so, on the employment questions, we know how many hours you work, what kind of sector you were in, did you have your own business, were you working for pay, what was your wage? Like, we try to capture all that. And as I mentioned, one of the really striking things about the first papers, we don't see big effects on that. We don't see these, say, reductions in employment for those who got the cash. For people who didn't get the cash, which I think was your question, we see some moderate improvements in the wages they earned. Because cash is going into those areas. There's more business activity. Firms have more revenue. They're hiring more workers. So there is that kind of spillover on the non-recipients.
Right. Okay. Thank you.
Thank you.
Hi, thank you so much for the talk. I'm sort of coming from a different background. I'm an undergraduate here, but I used to work with the World Food Programme in doing cash distributions and cash for work. And one of the big questions we had when working on the field was moving past dependency when we're on the path to resiliency. So moving from urgency-based solutions to resiliency-based solutions. One of the things that I was particularly interested in was how the population responded to these treatments, especially in regards to their life satisfaction and their agency. And we thought that there might be a response there or a solution there. I was wondering if your project, perchance, had sort of looked at these measures in terms of experienced well-being or subjective well-being and life satisfaction.
Yeah, I briefly mentioned it before, but we have happiness and life satisfaction questions. We actually had a whole module on sort of psychological well-being, feelings of agency. We have the MacArthur Ladder. We have these different measures, sort of how you see yourself in your community, self-efficacy measures, those kinds of things. And across the board, we see small gains, not transformative gains, but small gains. You raise a very interesting point about dependency. This is not a universal basic income program where people will get cash for many, many years. This is a one-time transfer, and it really was one time. After Give Directly gave, they moved on to other areas. And I think my understanding of the kind of philosophy underlying that for Give Directly was an idea that they didn't necessarily want there to be dependency, but they thought a really large one-time transfer could lead to very important investments. And one sort of permanent change from that one-time transfer that we've just shown is a lot more kids are alive. So it's easy to kind of look at the convergence back. Like I showed you that figure where after the cash ends, well, infant mortality is back where it was. And you might look at that and say, it didn't really do anything. The moment passed and now the cash didn't do anything. No, 100 kids are alive. And we're going to be able to, hopefully in the future, measure their long-term outcomes. So I do think in terms of dependency versus resiliency, we can't get at it directly here, but a one-time transfer is leading to some lasting change.
Thank you so much.
Yeah, thank you.
Hi, Professor. Thank you so much for your talk. I had a question. I was especially interested when you were saying that cash transfers, we shouldn't look at it just as should we or should we not, but rather, is it targeted and is it timely? I'm very interested in family policy, and I was wondering what your thoughts were on tracking the pregnancy cycle of each household, like what implications that has on privacy, especially with regards to like state policy, like a federal scale. So I know that as an economist, maybe that's like out of scope and it's about the data first, but how did you go about collecting the data in Kenya for those women?
Yeah, so what we asked them, and of course, I will say, I didn't even get into it, like all the surveys we run go through ethics approvals in Kenya through multiple bodies, in Berkeley, to make sure that it's ethical. People have the right to answer or not answer, consent, not consent. As I already mentioned, for certain sensitive modules like the VA, verbal autopsy, they may not, et cetera. In terms of asking about birth histories, we asked about like the timing of childbirth and then the deaths if they occurred. So that was given by respondents. There's no like ongoing pregnancy tracking. It was just like we know the timing of the birth, so we can go back 9 months and say, okay, that's roughly the in utero period. So it's something that people shared with us. Of course, the data is confidential. Research data often does get shared when papers are published in journals, but they're de-identified. We strip out anything that could link people to those answers. So I do think that from a privacy point of view, hopefully it's safe. The way it's carried out, and people have the right to say, I'll answer questions about my farming, but I don't want to answer about my health. That would be fine in the surveys.
That makes sense. Thank you so much.
Yeah, thank you for your question.
Let me just say before I pose my question that if any of the distinguished economists have a different answer than yours, I would like to hear it afterward. But I'm interested in the cost of a cash transfer to the people who are making these transfers. I recall that the man told me he was Undersecretary of State distributing $100 bills after the Iraq War. He said, well, if they don't come back to America, they really don't cost us anything but paper and ink. And to what extent is there actually a cost that comes back out of the communities for making this transfer, or does it just really spark the exchange of goods and services among the people in the community?
Yeah, I think it's an interesting point. At the scale that we studied, even though for an RCT, for an experiment, it's a large experiment, 11,000 people receiving cash transfers, say, for all of Kenya is still pretty small. So if we think there's some like broader effect on the Kenyan economy, it would probably be small. If I were to kind of extrapolate, if I'm understanding your question, like what if we really scaled up programs like this and gave out lots of cash like this? What could the broader effects be beyond the study region? Well, if there were a large enough program and enough cash were being distributed, eventually there would be inflation at the national level, at some point. So I think there is a question of, at what scale can you give out cash and distribute these resources without sparking inflation? At our scale, it was really minimal. But maybe at really large scale, you would see some adverse inflationary pressures.
But to what extent does it take resources away from other people who would need it? That's, it gives a certain edge in purchasing power to one community over another, but that may only spark more production.
Yeah, I mean, if I'm understanding your point, like in terms of where the cash comes from, Give Directly is basically a US-based NGO that's raising money from rich countries. So that's sort of where it's coming from. It's not being redistributed like within Kenya. It's like money from the outside. In terms of the, how it's spent in Kenya, all the transfers are targeted to the poor households. So it isn't like some are poor rich. They're kind of targeted to these poor households. So that's the way it's set up. Thanks. Yeah. Okay. Thank you.
Last two questions. Thank you very much, Professor. Mine is quite short. $1,000 is quite a transformative amount of money, but towards considering cost benefit, was there any research done in how much was the least amount of money that is possible to be given so that we see some levels of reducing of infant mortality?
Yeah. So the World Health Organization has a they review evidence on exactly this question, on the impacts of different interventions on infant mortality and what they cost. And in fact, in some of our other research, we kind of reproduce that evidence. So anything up to, I think it was $80,000 per life saved or $100,000, they considered cost effective. We were at $15,000 per life saved. There were a few interventions, and they had to do, again, with sort of like medical personnel interventions, like adding medical personnel into certain clinics, et cetera, that were even more cost effective at a few $1,000s per life saved in those studies. But we would be in like the group of the, I don't know how many, 5 or 6 most cost effective with this estimate. Now I do want to say, and this is just as a researcher, as a scientist, all of these estimates have confidence intervals, they have standard errors on them. So we have this $15,000 number, but there is a range of estimates that are kind of consistent with that. But the estimate, our kind of central estimate, would make it quite cost effective relative to this WHO review that we saw. Thank you.
I think he asked the same question I was going to ask, but so $1,000 sounds like a random amount.
I think it was a nice round number for the NGO. Honestly, I think that's why
it's a nice round number, but are you thinking about trying to figure out if you could get the same correlated social benefit for half the investment, or could you get 3 times the benefit for twice the investment? Those kind of questions. So from a policy point of view, you could aim in at the optimum stipend?
That's an awesome set of policy questions. We don't have the design to do that here, but this same NGO, Give Directly, and some other groups have been designing a series of other RCTs over the last few years to try to get at those issues. Smaller versus larger transfers, one-time transfers versus like basic income support. So there's a lot of innovation and studying going on right now in low and middle income countries. And also in the US, there have been a bunch of basic income experiments and cash transfer experiments in the US as well. So it's just a very exciting time for this work, and we're learning a lot around the impact of these programs. But from our data, we can't estimate those effects. So, yeah, thanks.
Thank you. Yes, this was the last question. We have to stop at some point, but I want to let us thank Ted.